Topic for this session is improving cardio-renal outcome in type 2 diabetes mellitus. And to speak on this particular topic, we have Dr. Swayamsidha Mangaraj from Odisha. He is a cardiologist, and to chair this particular session, I would like to invite Dr. Parthopratim Pal, who is Secretary IMA Howrah, and along with him Dr. Abhishek Raha, who is a consultant diabetologist attached to Indian Railway Service. We welcome Chairperson Sir and Speaker Sir on stage.
Good afternoon, everyone. Respected seniors, dear colleagues, I have a small correction to make that. I am an endocrinologist, not a cardiologist. But thank you for the organizing team for the kind invite, and I would like to applaud them and kudos to the organizing team for putting up a fantastic show. So I think we have heard a lot regarding diabetes, complications, management. So I will be speaking on two very specific complications which perhaps contribute to the mortality and morbidity in the maximum way. So I'll be talking regarding improving the cardio-renal outcome in diabetes mellitus. So this is the state of the health of the nation. So this is the data from 2022 ICMR INDIAB study published in Lancet, in which they have shown that around 66%, roughly 2/3 of the individuals do not have an optimal glycemic control that is mandated by ADA, a target of less than 7. This is nothing uncommon. The figures may be a bit higher in areas where we practice. Now moving on to the concept of residual risk. So despite availability of plethora of agents at our disposal for the last decade, we are not able to bring down the mortality which was seen almost a decade earlier. So the key contributors being presence of other complications like chronic kidney disease and heart failure. Chronic kidney disease, I think this is one complications which once sets in is going to jeopardize your long-term outcome, both with regards to renal outcomes as well as cardiovascular outcomes. Similarly, heart failure. Heart failure is one of the terminal events in the life of an diabetic. That means once a patient is diagnosed with heart failure, whether incipient or overt, this is going to be a progressive downhill course. Despite giving the best standard of care of therapy, we are not likely to achieve the desired goal. If you look at cardiovascular disease, majority of our diabetic patients are likely to die from a cardiovascular event in their lifetime. The risk is exponentially high. If you compare from non-diabetic individuals, roughly 2 to 5 times the risk is elevated in patients who have diabetes vis-a-vis those who do not have diabetes. The cardiovascular disease occurs almost a decade earlier in Indians and Asians versus Caucasians, and these are difficult to treat, and the outcomes are also dismal. If you talk regarding macrovascular complications, coronary artery disease, peripheral artery disease, or stroke, n number of studies, including landmark trials like DCCT, UKPDS, have shown that perhaps these are exponentially elevated in patients who are poorly managed. Similarly, heart failure. If a patient is diagnosed with heart failure, the risk of dying is almost 2 to 4 times than who do not have heart failure. If you look at chronic kidney disease prevalence across the globe, so this is the pooled data from an KDIGO cohort, in which they have shown roughly around 40% of your patients are likely to have some or other forms of albuminuric diabetic kidney disease. Roughly 10 to 20% would have both albuminuria and reduced eGFR, and less than 10% would have non-proteinuric diabetic kidney disease. That do exist, but the incidence is a bit rare. This is the data from the Valiant trial, in which the long-term follow-up of patients who had a myocardial infarction were followed up. If you see, compared to patients who have diabetics and those who have eGFR of less than 45, so those patients who have eGFR of less than 45, the purple column, they are likely to have the highest risk of having an adverse cardiovascular event, be it ACVD, acute myocardial infarction, heart failure, or stroke. Presence of chronic kidney disease, cardiovascular disease, and diabetes form a complex web in which each of these diseases influence the other in an adverse way, thereby diminuting the lifespan of an individual. This is the enhanced data of a decade in which they have shown that if your patient develops macroalbuminuria with a reduced eGFR of less than 60, the risk of CV death is almost 2 times in comparison to those who have a normal no albuminuria or who have a GFR of more than 90. When you have both, that means you are a diabetic and you have CKD, look at the purple line, purple bars, the risk is almost 2 to 3 times of any event you talk, whether heart failure, myocardial infarction, even cardiovascular death. It is almost 2.5 times more in patients who do not have diabetes or CKD. So to mitigate all this, what we follow is a multifactorial approach. The cornerstone being glycemic management. You give optimal therapy so that the blood glucose are controlled within the desired threshold. Manage blood pressure and lipid control with the appropriate agents. But that has been the management strategy for years together. What has now changed in the couple of years is utilizing certain agents which actually reduces your cardio-renal outcomes in the long term. These agents were perhaps not there with us almost a decade earlier. So the crux of the talk would be deciding and providing you evidences of these molecules. So if you look at the ESD-ADA joint consensus statement of management of diabetes, so you have to formulate a comprehensive strategy which has to be individualized, looking at the accessibility of healthcare, affordability, longevity, and comorbidities, so that the patient adheres to your treatment protocol and in turn the outcomes are improved. There is no one theory fits all. It has to be individualized, looking at all of these factors. Now what has really not changed? So this publication from NEJM, what it speaks, if you look at complications such as myocardial infarction, stroke, amputation, these have significantly reduced almost over the last 3 decades. You look at the curve graph, so they have steep decline. But what is not changed is the onset of diabetic kidney disease or the CKD. That has perhaps not changed in tune what other complications have changed. So the cause could be multifactorial, and I will show you data regarding some of those. In tune with the publications in the last decade, especially blockbuster CVOT trials, guidelines have realigned them along with the data which have come from them, and every guideline now endorses utilizing SGLT inhibitor or GLP analog, which has shown to improve cardiovascular outcomes if your patient has any form of atherosclerotic cardiovascular disease or is at a high risk for it. If your patients have heart failure, give SGLT2, which has shown to reduce all heart failure outcomes, especially with the publication of DAPA CKD, Emperor reduced, DAPA HF, Emperor reduced, and Emperor preserved. For chronic kidney disease, we will talk a bit later. So what paradigm change has occurred over the years is the molecule which was positioned as a glucose-centric molecule, merely reducing your blood glucose, has been now rebranded as an agent which is going to reduce your heart failure outcomes, a cardiologist domain, and is going to improve your renal outcomes, a nephro domain. So these drugs are now repositioned to actually improve chronic complications that was not available with us with any other particular subgroup of agents. SGLT2 inhibitors keep us surprising almost a decade after they have come into the market. So we all know the mechanisms are multiple and they induce certain changes which improve the state of the cardiovascular health much earlier, even before the anti-hyperglycemic efficacy sets in. So they improve how your cardiac myocyte functions, they alter the bioenergetic profile so that the fuel is utilized in a more efficient way, in turn leading to improvement in your cardiovascular disease status, all driven events that was seen in EMPEREC trial, in which merely 3 months of use of the drug, the lines began to diverge, the Kaplan-Meier curves diverge with regards to the primary MACE outputs. Now coming to heart failure, now with the publication of DAPA HF, Emperor reduced and Emperor preserved, SGLT2 inhibitors have been now a foundational form of therapy for managing heart failure, as with other agents including beta blockers and ACE inhibitors. So these are now a group of agents which are now classified as a foundational therapy for managing heart failure, irrespective of the patient whether it is diabetic or non-diabetic. last decade belonged to this molecule, SGL2 inhibitors. So EMPA-REG, DICLA-TIMI, CANVAS, VERTIS and CREDENCE are some of the trials which have shown improvement or superiority of these molecules. Some molecules in this class achieved the 3-point MACE improvement, whether some could not, but that could be purely due to the virtue of the nature of the enrollment of the participants in that particular trial. But the bottom line is, hospitalization for heart failure related outcomes and renal outcomes are significantly improved across as a class effect. So here I have summarized 3 predominant bigger trials of CVOT trials in which they have shown that utilizing SGL2 inhibitors is going to bring down your 3-point MACE endpoints and CV death if you talk about empagliflozin use. Similarly, canagliflozin also reduced 3-point MACE in that CANVAS trial. Whereas DICLA-TIMI, because the patient had majority a risk factor not established ACVD, they could not bring down the 3-point MACE or cardiovascular death. However, hospitalization for heart failure or CV death were improved in majority of them. A drug which is not spoken in the same breath is of GLP analogs. They do have certain benefits, but not as robust data exists with regards to in comparison to SGL2 inhibitors. So GLP analogs, these are highly efficacious. The A1C lowering capacity is almost around minus 1.5%, which is not seen with SGL2 inhibitors. They are much weaker drugs. There are drugs like liraglutide, injectable semaglutide, which have shown CV benefit with regards to their use in cardiovascular trials. But what I will specifically focus here is the renal benefit, which is very, very less spoken and talked about in majority of the meetings. The potential limitations or adverse events which preclude their use is cost, because our patients pay from their out-of-pocket healthcare expenditure for managing it. There are injectables bearing oral semaglutide and the GI side effects. So these are the class of agents which are available with us for our use. So if you look at the anti-hyperglycemic efficacy, as I told earlier, it is somewhere from -1 to -1.5% across the individual agents in this particular group. Now what they have shown in the CVOT trials, it is not a class effect. Many molecules could not reduce the 3-point MACE endpoints. Certain drugs like liraglutide, injectable semaglutide, these could actually reduce the primary 3 points MACE endpoints, and the latest one, the F-peglinatide, which also achieved the same in the Amplitude O trial. So here I have summarized all the MACE endpoints and the components, so I'll make it a bit easier. So in this primary MACE outcomes, you can see there is overall in the meta-analysis from which it was taken, they have shown improvement with regards to as a class of agent, GLP analog, but there lie subtle differences, like in the trials, you can see Amplitude O, that is for epaglinatide, that improved, Sustain 6 and Leader, these could improve the 3-point MACE endpoints or the MACE endpoints in the GLP analog trial. Some drugs also improved all-cause mortality in these, but that is not as a class effect. Individual drug had some different benefits with regards to their use. So in tune with this, what the AD has endorsed, that any patient who has any form of established or a high risk for ASCVD, you give an agent, predominantly SGL2 inhibitor or GLP analogs, which has shown to improve these outcomes in clinical settings. DAPA-CKD was the predominantly first dedicated CKD trial to robustly demonstrate the improvement in the renal outcomes, whether decline in the eGFR, reduction in the all-cause mortality, or even the composite endpoints of cardiovascular death and hospitalization for heart failure. That was also replicated in CREDENCE by canagliflozin and EMPA-KIDNEY, improving endpoints across the albuminuria excretion, eGFR reduction, and improvement with regards to surrogate secondary endpoints. So what they have safety concerns, majority is the genital mycotic infections which go with proper counseling and hygiene maintenance. Euglycemic decay is exceedingly rare but do occur, and you have to be careful for volume depletion if you are giving this agent in elderly patients. So if you have CKD, please prescribe an agent like SGL2 inhibitor, which will retard decline in eGFR, will improve your albuminuria rates, and in the long term will also improve your cardiovascular outcomes. KDIGO guidelines also endorse that. We'll also focus how ideally you should manage a patient who is diabetic with CKD. I think we have already discussed that they alter many of the intradynamic mechanisms or hemodynamic mechanisms through which benefit of SGLT2 inhibitors, improvement in the renal outcomes are observed. But what is not frequently discussed is how GLP analogs are going to bring down your outcomes. So this predominantly we do not know much as of yet how exactly this induces that change, which could be driven through reduction in the oxidative stress, inflammation, or hemodynamic alteration. Patients should receive SGLT2 inhibitor, RAS blockade at optimal dose. Two other drugs which they have advocated is addition of GLP analog to reduce the glycemic endpoints. There is no robust data as of now to reduce the renal endpoints as of now. You can add a drug, finerenone, which is a non-steroidal mineralocorticoid receptor antagonist. So these are the drugs which are going to reduce your renal endpoints as of now. What we are lacking is a dedicated head-to-head trial of GLP analog versus SGLT2 inhibitors taking renal outcomes as a primary endpoint, or a trial, let's say, of a GLP analog with a dedicated renal outcome, like Credence with SGLT2 canagliflozin, DAPA-CKD with dapagliflozin. This is going to be addressed by a trial which is known as FLOW trial, in which oral semaglutide is being tried for dedicated renal outcome, for the result which we will have in coming years. So this is the meta-analysis of the CVOT trials as a secondary endpoints. You can see in this meta-analysis also they have shown that if you look at the bottom column, there is improvement in the macroalbuminuria and the functions in patients who are given GLP analogs. Now, I will just show you data which is again re-stratified based on whether you are taking that composite endpoints with macroalbuminuria or without macroalbuminuria. You can see the composite endpoints are improved. I think it's not working. So the composite endpoints in the left-hand column are improved with the use of GLP analogs. But if you take patients who do not have macroalbuminuria, that benefit is gone. So perhaps they improve the secondary renal endpoints by improvement majority driven through the albuminuria. So these drugs are safe, efficacious with regards to anti-hyperglycemic efficacy. They induce weight loss. There are drugs which are specifically available as a weight loss agent. If you talk of injectable semaglutide or even the newer dual twin creatine tirzepatide, which are going to reduce your weight to the tune of 10 to 15%, 20%, which was even not possible, unheard of, except in the settings of bariatric surgery. So I think the patient, if affordability is not an issue and tolerability is not an issue, these agents should also be used in conjunction with SGLT2 inhibitors in that setting. Okay. So the last few slides of finerenone. So Fidelio and Figaro, these two trials came up in the couple of years back, and what they have shown is that this drug is a non-steroidal mineralocorticoid receptor antagonist. Utilizing these drugs is going to bring down your CKD endpoint by 18% in the Fidelio DKD trial, and it brought down Figaro, being a predominantly CVOT trial of finerenone, that reduced the primary endpoint by around 13%. But that was predominantly driven by reduction in the hospitalization for heart failure, not by reduction in the acute myocardial events. But nonetheless, we did not have a drug in the past except bearing SGLT2 inhibitors which could improve renal outcomes. But this drug can be used in conjunction with SGLT2 inhibitors as a foundational therapy for improving your renal outcomes. Benefit is the hyperkalemia, which is seen with use of finerenone, can be mitigated to some extent with the use of SGLT2 inhibitors. Now, there are trials which are going on to test the efficacy and safety of combining these two drugs to look for the improvement in the renal outcomes. So ADA guidelines, ESD guidelines, all of these perhaps say the same thing, that if your patient has any form of chronic kidney disease, please prescribe an SGLT2 inhibitor that is going to retard the progression of the disease irrespective of the glycemic anti-benefit. Initially, if you remember, the threshold was less than 45. It was brought down to 30, 25. Now, EMPA kidney brought it down to less than 15. So you may not reap the benefit of glycemic efficacy, but the renal outcomes, cardiovascular outcomes, these benefits continue to be accrued with the use of the drug. So to summarize, diabetes perhaps remains the biggest threat to mankind in this century, not only with regards to the healthcare expenditure, but also to the contributor of morbidity and mortality, especially in India, where the earning segment, the patients who are poor are more suffering from the disease and its complications. Our treatment strategy has evolved from a glucocentric to patient-centric, perhaps mitigating, giving you a comprehensive plan to manage your metabolic health with regards to improvement in cardiovascular and renal health, not only reducing your blood glucose and merely looking at the numbers. SGLT2 inhibitors, GLP analogs perhaps form the crux of this paradigm shift, which is going to happen in the subsequent decade, and definitely improvement in the outcomes which was not seen in routine clinical practice, such as reversibility or at least remission in the CKD or retarding the progression of CKD, that is commonly seen in routine clinical practice as of now. So again, thank you all for the patient listening, and we can have some discussion if any questions are there. Thank you.
Thank you, Dr. Swayamsidha Mangaraj. It was a very elaborate presentations that you have up to. So I open it up for the audience to have one or two questions.
Thank you, Dr. Swayamsidha, such a nice and elaborative lecture. My question is that apart from controlling blood sugar and blood pressure in diabetic kidney disease, we are giving SGLT2 inhibitor, ARB, and latest is finerenone, because that is also a very good molecule and it increases potassium less as compared to other molecules. So, because finerenone is such a costly molecule, so can we use mineralocorticoid receptor antagonist like spironolactone, keeping in mind that it will increase potassium, that has to be monitored, but because we are a poor country, everybody cannot afford finerenone, so in low doses, spironolactone taking care of serum potassium, will it help in decreasing progression of diabetic kidney disease?
I think excellent question, sir. That question was, I think, perhaps thought of by some other investigators. A Japanese trial was published recently in JCM, Journal of Clinical Endocrinology and Metabolism, in which they have addressed the same question, utilizing spironolactone as a cheaper alternative to finerenone. Yeah. What they have suggested is it can be used. The results are not as robust as finerenone, but if your GFR is more than 45 with patient with periodic follow-up of potassium monitoring, you can try. That isn't something called a poor man's finerenone. We can try it, but the problem is if your GFR comes down less than 45 and patient is already, let's say, RAS blockade or ACRB, then caution should be exerted with regards to its use. But that remains a poor man's finerenone.
Taking that question ahead, previous to finerenone, we were actually using spironolactone only. Spironolactone has been age-old, been used MRA drug from the time DKD has been treated, because that was the second line drug to control proteinuria after ARB. Only because of hyperkalemia and the side effects, we started using it less. But the effect of spironolactone on GFR is higher as compared to finerenone. When there is any alteration in blood pressure, suppose the patient has a volume loss, diarrhea, infection, that time spironolactone works like a double-edged sword and creatine starts rising. So this is what practically we have seen. But over the course of time, what Dr. Saab has said, that proteinuria has been well studied in the recent Figaro and Fidelio trial. That is why it is more of industrial driven molecule which has come up in a big way. Practically before, still as Sir said, spironolactone was the drug of choice for poor man's drug. After ARB, that was the second line we were using.
Fluid loss condition, anyway we have to stop SGLT2 inhibitor as well as ARB to prevent acute kidney injury. And that is same with spironolactone. And spironolactone being a long-acting drug, even we can use alternate day in low dose like 12.5 milligram. We can use even alternate day, it will work.
But the problem is you don't get this patient at the very time when you stop these drugs. Patient may not present to you, patient may go to any physician, that time control it. Yeah. Only that depends upon the patient's understanding, then probably then you have to explain this thing. But yes, spironolactone was the drug before being used, finerenone.
Even sir, if you talk regarding hyperkalemia, in the Figaro and Fidelio, what they have shown is the number of events of hyperkalemia is significantly higher in comparison to placebo, but that did not translate into meaningful clinical events. That means no excessive death was recorded, no excessive arrhythmia was recorded in that particular trial. But the number of hyperkalemic events remain higher versus placebo because of the nature of the drug.
Thank you, sir. Sir, kindly be on stage, kindly. I would like to request chairpersons for the felicitation of Dr. Swayamsidha Mangaraj, endocrinologist who have joined us all the way from Odisha. Thank you, sir, for being there. Thank you, sir, for such an insightful session. I would also like to request Dr. Bismay Kumar to kindly, sir, come on stage and felicitate our chairpersons for this session. Thank you, chairpersons, for chairing this particular session, and thank you once again, speaker sir, for joining all the way from such a long distance on the 8th annual conference of Howrah Diabetes Study Society. Thank you all. With this, we move on to the next part of the scientific fiesta today, and the topic for the next session is: should all people with diabetes and CKD be on SGLT2 inhibitors? To speak on this particular topic, I would like to invite Dr. Ipshita Ghosh ma'am, who is a very well-known endocrinologist. And to chair this particular session, I would like to invite Dr. Shupriya Dotto, who is a physician and endocrinologist, and along with her, Dr. Bismay Kumar sir, nephrologist and also member Scientific Affairs of Howrah Diabetes Study Society. Speaker and chairpersons, I invite you on stage.